Good morning, or afternoon, or evening, everyone. It's a tremendous honor to have been awarded this year one of the Gairdner International Awards. And I take this honor both to myself and my lab, and also on behalf of all of the women and their families who have worked with me for the last 47 years to understand the problem of inherited predisposition to breast cancer. My assignment today is to tell that story, which I do with great pleasure. So here we go. The genetics of inherited breast and ovarian cancer, from gene discovery to precision medicine and public health. This story actually begins with writings from the ancient Greek physicians. We read in the writings of Herodotus that he had treated women in families who were very severely stricken with breast cancer, and it was a puzzle he didn't understand. More recently, in 19th century France, Paul Broca, the brilliant 19th century French surgeon and neurobiologist and anatomist, described inherited breast and ovarian cancer in his Traité de tumeur in 1866. Here's one of the families that Broca described. All I've done here is convert Broca's paragraphs into a modern pedigree. As you see, Broca was describing in this family breast cancer, which had occurred in 4 generations of women. A marriage is represented by a horizontal line, and the children from that marriage by dropped vertical lines and symbols from them. Women are circles, men are squares, and a deceased person is a slash through their symbol. Broca also described in this family not only breast cancer at very young ages, even by the standards of 19th century France, but also, he said, cancer that he was seeing in other organs, for example, in the liver here, in the abdomen here. But, wrote Broca, I wonder if these cancers are not cancers of the liver, but are cancers that have metastasized to the liver. I wonder, wrote Broca, if these may be cancers that originated in the ovary. He was, of course, working from tissue material from patients who had died long before he had access to the material. So gold star for Broca. He was almost certainly describing one of the first families with inherited breast and ovarian cancer. So we're going to skip the next 130 years, and we're going to jump right to the time that after the identification and cloning of BRCA1 and BRCA2, and I'm going to tell you their story. So I'm going to show you some pedigrees to begin with, and then we'll discuss some of the clinical implications of what we've seen. So here's a family, the first family that I began to study, family number 1 in my series. We're now up to family 6,200 and something. A family in which, as you see, breast cancer has occurred in multiple generations. The ages at onset of breast cancer or a diagnosis of breast cancer are very young in this family. And as you can see in this family, unlike the family that Broca described, but in this family, breast cancer predisposition can be inherited either from mothers, as here, but also from fathers, here, 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 and so on. Note also that in this family, not only do we see breast cancer, but we also see ovarian cancer in some women. And as we shall see later on, we also see prostate cancer in some of the men. It's also possible, although quite rare, to find a woman in a family like this one who has not developed breast cancer despite carrying the mutation of her family. When, of course, I know this family well, and when I spoke to this lady about this point, this lady in her 80s, I asked about all of the non-genetic risk factors for breast cancer, and she said, don't you think that if I had understood how I escaped from breast cancer, given how many of my relatives have suffered from it, that I would have told my daughter? Fair enough. What we now realize, now that BRCA1 and its sister genes are cloned, is that the development of breast cancer or ovarian cancer in a family like this is the consequence of 2 mutations. One inherited, which is represented by the V here, and which is inherited in a straightforward Mendelian way in this family. And the second mutation, a somatic, that is tissue-specific hit that occurs that abrogates the remaining still functioning copy of BRCA1 in the critical tissue, whether it's breast or ovary. Here's another family that I want to show you in order to make a couple of points. First, most of the mutations in BRCA1 and the sister genes are like the ones that I showed you in the previous slide. The mutation breaks the coding sequence and completely destroys translation of the gene into protein. This mutation is an exception in that it alters the specific amino acid. It's a missense mutation rather than stopping the translation of the protein. And as you can see here, the mutant allele co-segregates with breast cancer in the family. The consequence of this mutation was quite brilliantly elucidated by my friend Rachel Clevitt and her group just upstairs from me here in Seattle, to be the loss of E3 ubiquitin ligase activity of the BRCA1 protein, which makes a beautiful heterodimer, a beautiful partnership with the BARD1 protein. And this is extremely important for understanding breast cancer function generally, because the BRCA1 and BARD1 partnership, when they're functioning well, when they're functioning normally, act to process the estrogen receptor properly. So this means in the absence of proper functioning of this beautiful heterodimer, this pas de deux of BRCA1 and BARD1, we do not have proper processing of the estrogen receptor. And we have consequently aberrant regulation of estrogen and ongoing consequences, as we see here, for risk of breast cancer. BRCA1 as a whole, as we shall see in a few minutes, functions with a critical role in repair of double-stranded breaks in DNA. This is a second function of BRCA1, and both are critical to normal functioning of breast and ovarian epithelium. I want to show you this family because this is to make a special point about BRCA2, because this is a truly exceptional family. BRCA2 was mapped and cloned after BRCA1. BRCA1 had taken my group 17 years to map and thereby prove its existence, and had taken an international competition of many groups about 4 years to clone. We were not the ones who first cloned it. BRCA2, in contrast, was mapped in a year and cloned in a year, and the difference was that the Human Genome Project had come online in the interim. I've always thought that BRCA2 should be called John Sulston's gene in consequence, because it was the consequence of John Sulston insisting that this information be public and made available immediately, that the groups working on BRCA2 were able to move so quickly. So my group had nothing to do with the cloning of BRCA2, but this is one of the families in our series, in our studies, that turned out to have a mutation in BRCA2. And as you see, BRCA2 predisposes to breast cancer in young women, as shown here, but also to breast cancer in men. Now, in this family, there are more cases of male breast cancer than I have ever encountered in any other family, but the risk of breast cancer in men with BRCA2 mutations is real, pretty much across the spectrum of mutations, although not as high as shown in this family. This family is way out at the end of the distribution. That question, what is the risk of breast or ovarian cancer among women who carry devastating mutations that in BRCA1 or BRCA2, that is, mutations that either completely abrogate translation of the protein or that destroy its function, as in one of the families I showed you earlier. That question was difficult to address, because in order to address it well, one must identify families, not because they are at extremely high risk, not because they are so severely affected as the families I've just shown you, but families from the general population who carry mutations in these genes. And we carried out a study like that with unbiased ascertainment of families in 2003. And my friend in Jerusalem, Frat Levi Lahad, carried out a truly population-based study in 2014. And here are the results. They are essentially the same for both her study and mine. These are the results from her study in 2014. As you see, the risk of developing breast or ovarian cancer, whichever occurred first, among women with BRCA1 mutations, that is, damaging loss of function mutations in BRCA1, reaches about 80% by age 70. Among women who carry similar complete loss of function, mutations in BRCA2, the risk of developing breast or ovarian cancer, one or the other, reaches 70% by about age, in the 70s, by about age 80. Now, part of the reason that this question was so controversial for so long was that earlier cohorts of women who had been studied by our colleagues hadn't revealed such dramatically high risks. And here's why. If we take the data from a FROT study, in other words, the same women who were on that previous slide, but instead of separating them by the gene that harbors their mutation, by BRCA1 versus BRCA2, we instead separate them into two groups based on when they were born. And we've picked just the midpoint birth year of the study. There's nothing magical about 1958. So half of the women on that previous slide were born before 1958 and half were born since 1958. And then we plot the same data. What is their risk of developing breast or ovarian cancer if they harbor a devastating mutation in BRCA1 or BRCA2? And as you see, that risk for women born before 1958 is indeed very high. But it's even higher among women born since 1958. In other words, this whole age at onset curve is shoved to the left, is shoved earlier. This difference cannot be genetic. These are the same women in the same families, the same mutations. The difference is due, we speculate, to the increased prevalence of non-genetic risk factors for breast cancer. That is, early age at menarche in young girls in consequence of improved diet in young girls, and later age at first pregnancy in young women in consequence of greater education of young women and intentionally postponing pregnancies. There is also an element of improved diagnosis, which might give us a couple of years, but in no way does improved diagnosis alone explain this very dramatic difference in earliness of diagnosis of breast cancer among mutation carriers born more recently. This phenomenon has now been observed on 6 continents. That is, that in more recent cohorts, we see earlier diagnosis of breast cancer among women with the same mutations. It's anticipation, but it's anticipation for non-genetic reasons. So what about women who learn that they carry a mutation in BRCA1 or BRCA2 only after their cancer is diagnosed? It took 20 years, but BRCA1 and BRCA2 led to opening really a rich vein of research on the biology of homologous recombination repair-based repair of double-stranded breaks in DNA, and consequently to the development of what is called synthetic lethality for treating BRCA1 or BRCA2 cancers. Let me show you what I mean. So in normal cells, any kind of normal cell, when a break occurs, a double-strand break occurs in DNA, that break can be repaired in one of several ways, 2 of which are shown here. The most powerful repair is by something called homologous recombination, which involves several enzymes, of which BRCA1 and BRCA2 are 2 of them. And those proteins repair DNA here, they make loops, and then by recombination, they recreate the healthy DNA strands. And the cell goes on about its business and everything is fine. There's an alternate method of DNA repair called alternate end joining, or EJ, which is more error prone and not as effective, but it works. And it is dependent on another group of enzymes, different group of enzymes, of which PARP1 is one. And that kind of repair occurs in consequence of creating new DNA from microhomologies as shown here. So in this case, we also see the cell going on about its business, but there tend to be more mutations in these cells in consequence of imperfect repair of DNA. Now, that's under normal circumstances. What happens if we have a tumor that develops, let's say, in the ovary, because of the combination of an inherited mutation and an ovary-specific, a tissue-specific mutation that destroys the second previously normal allele of BRCA1. Could be BRCA1 or BRCA2, let's suppose BRCA1 for this example. That means that when double-strand breaks occur in DNA in such a cell, homologous recombination repair cannot occur because there's no more BRCA1. And this whole complex, which is called the RAD51 complex, of which BRCA1 and BRCA2 are both part, including that beautiful pas de deux that I showed you earlier, that kind of recombinational repair cannot work because the complex isn't there to do it. So the whole recombination machinery is pushed into this alternate in-joining pathway. And it goes on about its business, albeit with some damage to the DNA along the way. What biochemists working on the biology of DNA repair in consequence of understanding BRCA1 and BRCA2, what these biochemists discovered is that if one destroys this alternate pathway, as here, one has completely destroyed the possibility of DNA repair, but only in cells that have lost the homologous recombination repair pathway. That is, only in the tumor cells that have that second hit, as well as the first inherited hit. So that means that in tumor cells that have 2 mutations in BRCA1 or 2 mutations in BRCA2, if one treats with a drug that will destroy this alternate pathway, and these drugs are called inhibitors of PARP or PARP inhibitors, there is now no way that this cell can repair its DNA when it's broken. And what does that do? That enables conventional good chemotherapies to be extremely effective for these patients. So the development and perfection of this so-called synthetic lethality, because we are now creating a cell that is lethal, and we've created it so it's synthetically lethal to the action of chemotherapies, cisplatin chemotherapies, is now a reality. And here's the evidence of that. So this is the result of a very fine clinical trial undertaken to test a PARP inhibitor called olaparib versus a placebo in a randomized trial among women who had already had their primary treatment for ovarian cancer, and each woman on the trial had an inherited mutation and a somatic mutation in either BRCA1 or BRCA2. And as you can see, women who were treated with olaparib had far better survival than women who were treated with placebo. So much better, in fact, that the trial was stopped and everyone was moved on to olaparib. As my young colleague, Barbara Norquist, who's a gynecologic oncologist, said, she participated in this trial, she said, it is amazing to be able to cure women with ovarian cancer. The hazard ratio for disease progression or death is 0.28, just remarkable. Of course, this kind of treatment is only effective for tumors that have mutations in BRCA1 or BRCA2 that completely abrogate that homologous repair recombination. Once the study was complete and overall analysis was undertaken, including analysis of other causes of death, because as you might imagine, there was concern that PARP inhibitors might have side effects that would increase, say, cardiovascular issues. The overall reduction in cancer progression or death was 70% for women who were on olaparib compared to placebo. So everything I've told you led to recommendations from the National Comprehensive Cancer Network. This is a group of oncologists from all over North America who write annually guidelines for treatment of all kinds of cancer. And their guidelines for treatment of BRCA1 and BRCA2 mutation carriers are here. For prevention, they recommend annual mammogram and breast MRI screening from age 25, so much earlier than for women as a whole. that women discuss with their provider the option of risk-reducing mastectomy. And then a very strong recommendation, very explicit. They recommend salpingo oophorectomy at ages 35 to 40 or upon completion of childbearing, even with possible short-term hormone replacement therapy for young women who will go into menopause upon salpingo oophorectomy. For women who carry mutations in the genes. And then a study by Stephen Narod that I wanted to remember to tell you about is that for women who had had salpingo oophorectomy by age 40, that is at the age now recommended, there was a 77% reduction in all-cause mortality. That is, there was no devastating effect of any other cause in consequence of undertaking this preventive surgery. And then for women who learn only at the time that they have had their cancer diagnosed, that they have an inherited mutation in BRCA1 or BRCA2, PARP inhibitor therapy is recommended for BRCA null, ovarian and breast cancer, the sorts we've just been talking about. So all this suggests that it would clearly be of enormous help for women generally to know if they carried a mutation in BRCA1 or BRCA2 and to know that before they developed a cancer. So what are the challenges to identifying women at such high risk? Well, there are really three types of challenges. First, as we'll see, about half of women who have mutations in BRCA1 or BRCA2 have no close family history of breast or ovarian cancer. Second, there are thousands of different mutations in BRCA1 or BRCA2, each quite recent, each individually quite rare. And BRCA1 and BRCA2 are not the only genes involved. There's that all the genes in that complex are implicated in this story. So the dam broke on being able to identify mutations for women generally, not just for women from extremely high-risk families who would have certainly a reason to undergo sequencing, no matter how expensive and challenging it might be to have it done. And that was the development of a gene panel by my colleague, Tom Walsh, about a decade ago, a gene panel that we named for, of course, Dr. Broca. And this panel enables us to detect all classes of mutations, point mutations, big mutations, all classes of mutations in BRCA1 and BRCA2, and as we shall see, in all the other known and candidate breast and ovarian cancer genes. It's much less expensive than screening genes one by one. It used to cost about $3,800 to screen only 2 genes, and now it costs less than $200 to screen all the critical genes. So let me show you what that has meant. So among US Black and white women, we and our friends at the University of North Carolina carried out a study in which we screened Black or white women with breast cancer, not selected for family history, not selected for age of diagnosis. And we used BRCA to screen DNA extracted from blood, so germline DNA, from thousands of these women. And then we compared women who had developed breast cancer to women who had not. And among women who had developed breast cancer, 6% of all women with breast cancer, not selected for family history, and regardless of their age at diagnosis, and 9% of TNBC, that is triple negative breast cancer, had a loss of function mutation in one of the highest risk breast cancer genes, BRCA1 and BRCA2, which we've already talked about at great detail, and PALB2, which is a close relative of BRCA2, or P53, which predisposes to very early onset breast cancer, and in most families also to childhood cancers. What about ovarian? Oh, and here are the actual risks associated with mutations in those genes. If we compare the proportion of women with mutations in these genes among women who develop breast cancer compared to women who have not, a huge 27-fold increase in risk for breast cancer among BRCA1 mutation carriers, over 8-fold increased risk of breast cancer among BRCA2 mutation carriers, the same among PALB2 mutation carriers. Recall, this is the close relative of BRCA2. And blessedly, mutations in P53 are very rare, but a very high risk of breast and childhood cancers in those families. The same genes cause inherited breast cancer among women of all ancestries. We studied Black and white women in the North Carolina study, but the same is true for Asian women. But the mutations are many. There are thousands of different mutations in each of these genes. Each mutation is individually rare. Each mutation is very specific to one place and one time, often indeed to one family. What about ovarian cancer? We were surprised to discover that 18% of ovarian cancer is inherited. And that's not simply in families that have been severely affected with breast ovarian cancer. That's among ovarian cancer patients generally. In other words, if we could screen women for mutations in these genes at a young age, as young adults in their 30s, and learn who carried mutations in BRCA1 or BRCA2, and offer them preventive surgery at about age 40 for removal of the ovaries and fallopian tubes, we could prevent 18% of ovarian cancer. It would be a remarkable thing to be able to do. It's logistically possible. Note, please, that 1 in 3 of the patients with mutations in this series of ovarian cancer patients were diagnosed after the age of 60. So let us not forget about those of us who are older than 60. Certainly among breast cancer patients, ages at diagnosis are much younger among women who carry mutations in BRCA1 or BRCA2. But for ovarian cancer, the age range is, it's a little younger than for ovarian cancer generally, but not dramatically so. All women with ovarian cancer should certainly be tested for mutations in BRCA1, BRCA2, and the sister genes. PARP inhibitors may be effective for many of these patients, not only for patients with mutations in BRCA1, BRCA2, but also for women with mutations in any of the homologous recombination repair genes. And here are the elevations in risk among women who carry mutations in these genes. They are, as you see, extremely high, 29-fold increased risk of breast cancer among BRCA1 carriers, and so on. The risks, the relative risks, the odds ratios are even higher than for breast cancer among women with mutations in these genes. That's largely because the background rate of ovarian cancer is much lower than the background rate of breast cancer. And what about prostate cancer? So work by my young friend, Colin Pritchard, and his colleagues at the Fred Hutch and collaborating institutions showed quite recently that 12% of advanced or metastatic prostate cancer is inherited. Again, their patients were not selected for family history or age of diagnosis. They evaluated these patients with BRCA, just as we explained. And as you see, BRCA2 is the principal culprit here. And ATM and CHEK2 are also, alas, major contributors, and they are also contributors to the breast and ovarian cancer stories. And very importantly and hearteningly, the experience of treating breast and ovarian cancer patients with synthetic lethality, that is with PARP inhibitors, has informed treatment of these prostate cancer patients who carry inherited and tissue-specific mutations in BRCA2 or its sister genes. So I like to say that our colleagues who are oncologists of prostate cancer have essentially skipped the landlines. They've taken advantage of all of the experience with breast and ovarian cancer and are now exploiting that information for the benefit of their patients. And a major question now is, what are the absolute risk of prostate cancer? First, prostate cancer that is not yet metastatic, and then metastatic prostate cancer to men with these mutations. And our colleague Heather Chang is investigating this story in the Pacific Northwest. So what are the themes that we've discussed? Here they are. First, mutations in BRCA1 and BRCA2 and PALB2 and so on are individually rare, but collectively quite common. Second, cancer develops when, but only when, we have inherited and somatic mutation in the same gene. Next, the critical genes, when mutant, lead to loss of DNA repair. Next, many genes can cause inherited breast cancer. You saw the pie charts, but each patient has an inherited mutation in only one gene. Next, there's important interaction in time and space between gene and environment. We saw that with the change in diagnostic age among women with BRCA1 and BRCA2 mutations, depending on the time that they were born. That is the year in which they were born. And finally, that somatic events, either genomic somatic events or epigenetic somatic events, that is methylation events in breast or ovarian tissue, in the same genes, have the same effect as inherited mutations. I haven't discussed this, but it's important, and it is now embedded in the analysis of tumors of breast, ovarian, and prostate cancer patients. So all of this information led my friends and me several years ago to make a proposition. That is that every woman, cancer-free women, be offered complete sequencing of BRCA1 and BRCA2 at about age 30 as part of routine medical care. That is, simply make the offer for sequencing. It just be part of let's say, a gynecologic exam. That women with a severe family history that's not resolved by BRCA1 or BRCA2 be referred for testing for all breast and ovarian cancer genes. And that women with an unambiguously damaging mutation, all the ones we've talked about today, be referred to a high-risk clinic for appropriate follow-up. Now, when we first proposed this idea several years ago, it was thought to be very radical. It's no longer thought to be so radical. And the reasons that it has now become much more mainstream, are the following. The technical quality of sequencing, commercial sequencing, sequencing by hospitals and so on, has improved vastly in recent years. It's now clear what the yield, that is what proportion of cancer-free young adults will be that carry a mutation in one of these genes. And it's about 1% on average for North America. It's certainly higher in some populations. It's about 2.5% in the European Jewish population in North America. It's higher in the population of French Canadians in North America. On average, it's about 1%. The cost has dropped enormously since the decision in the Supreme Court of the United States, that's SCOTUS, to abolish the patents that had been maintained by the company that cloned BRCA1 and BRCA2 since the mid-1990s. And in 2013, the US Supreme Court ruled unanimously that genes are products of nature and cannot be patented. And that opened the markets immediately, literally overnight, to a much wider number of firms offering sequencing, and the cost dropped almost immediately, within weeks, more than 90%, because all of these modern tools could be brought to bear and market forces were at play. There's been a great improvement in interpretation of mutations whose consequences are not as clear as the mutations that we've discussed in the last few minutes. And that improvement has been brought about by expert panels who've devoted a great deal of time, mutation by mutation, to understanding the consequence of every change in BRCA1, BRCA2, and the sister genes. We also know much more than we did previously about how to follow up families by offering genetic testing, what's called cascade testing, to other family members. And most importantly, we know more about how to offer medical follow-up to mutation carriers. You have, of course, with your health system in Canada, taken strides beyond what we have taken in the US in making this follow-up available, regardless of the insurance status of the woman and her family who carry a mutation. So all this is by way of saying that every breast or ovarian cancer patient with a BRCA1 or BRCA2 mutation that is detected only after diagnosis is a missed opportunity to have prevented a cancer. No woman with a mutation in BRCA1 or BRCA2 should die of breast or ovarian cancer. It is completely preventable, and it is absolutely unnecessary. Thank you very, very much.